My patient is Robert California. He is a 61-year-old Caucasian male. Robert is hearing impaired and he has COPD, chronic obstructive pulmonary disease. He is a social drinker and smoker, and he is divorced. For Robert's medications, he uses ipetromium bromide for his COPD. It's taken as a nebulizer, inhaled 3 to 4 times per day. With this, you do not want to mix with alcohol, so if he's considering drinking that night, he would not use this medication. Contraindication is to not use it if you're allergic to tiotropium. And some oral side effects of this medication is xerostomia, which can cause decay, nausea, and sinus pain. For his hearing impairment, Robert has a hearing aid. This has no oral effect, but it would have an effect on the dental appointment. We could make sure that the patient is seen early when there's less noise in the office. And also, if you're going to use the Cavitron, you would tell a patient with a hearing aid to turn it off before you turn on the Cavitron. For Robert's medications, for Robert's periodontal assessment, we can see he is a generalized case type 3 moderate periodontitis with localized case type 4 severe periodontitis in the posteriors. Robert's pocket depths and clinical attachment loss reach all the way up to 9 millimeters in the upper right quadrant. His upper right and lower right are his most severe pocket depths, and his clinical attachment loss ranges from 2 to 9 millimeters in the posteriors. He has generalized bleeding throughout the oral cavity. We can even see some class 3 furcations. So his periodontal case type, again, is generalized case type 3 with localized case type 4. For Robert's AAP periodontal classification, he exhibits the 1B non-plaque induced. This is related to his medications, for his systemic disease, which caused bacterial and fungal effects in his mouth. His extent is localized for the severity of severe more than 5 millimeter clinical attachment loss, and the extent generalized for the severity moderate 3 to 4 millimeters clinical attachment loss. For Robert's 88 periodontal case type, he exhibits class 3 moderate periodontitis, generalized. We see the 5 millimeter and 6 millimeter probing depths. We see bleeding and recession, alveolar bone 3 to 4 millimeters below the CEJ, horizontal and vertical bone loss, 3 to 4 millimeter clinical attachment loss, furcation, and 16 to 30% radiographic bone loss. That is all generalized. For the class 4 severe periodontitis, we see it localized. We see probing depths more than 7 millimeters, bleeding, recession, class 2 and 3 furcations. We also see alveolar bone 5 millimeters or more below the CEJ, horizontal bone loss, vertical bone loss, more than 5 millimeters clinical attachment loss with furcations, and more than 30% radiographic bone loss. So once again, class 3 generalized, class 4 localized. Robert's gingiva presents as dark pink in some areas and bright pink in a few areas. This is a moderate severity and the distribution is diffuse. The contour is rolled and receding. The papilla is bulbous. It is very severely bulbous and receding. The consistency is very severely swollen up to the free gingiva, and the surface texture is moderately shiny. My patient presents with generalized chronic moderate periodontitis and localized chronic severe periodontitis, affected by xerostomia from COPD medication. Patient presents with recession and class 3 furcations on tooth number 14, 15, 20, and 21. In this radiograph, we can see class 3 furcation, vertical bone loss of over 5 millimeters below the alveolar crest, and horizontal bone loss 3 to 4 millimeters below the alveolar crest. In this gingival image, we can see a loss of stippling and shininess of the gingiva, blunted contour, dark pink gingiva with red margins, swollen and bulbous gingiva, receding margins, rolling, and calculus deposits. Based on the progression of severity and the extent of bone loss, the prognosis is bad for my patient, verging on hopeless. Short-term goals would be to arrest inflammation through SRP. Long-term would be to adjust diet through nutritional analysis and recurring 3-month perio maintenance appointments. A referral to a periodontist for surgical interventions would also be recommended. Some modifiable risk factors would be oral home care, nutrition and diet, alcohol consumption. Some non-modifiable risk factors would be hearing impairment and the effects of the medications for COPD. Our treatment planning would include a comprehensive periodontal evaluation, periodontal scaling and root planing for 4 or more teeth per quadrant, gingival irrigation, periodontal maintenance, fluoride application, and oral hygiene instruction. We would start with a comprehensive periodontal evaluation, which would decide our plan for SRP and any referrals that we would need to make to Robert. After the SRP, gingival irrigation, fluoride application, and oral hygiene instruction would be done. Then Robert would continue to come back for 3-month periodontal maintenance visits. Instruments selected for Gracie's would be after 5s, mini 5s, and micro mini 5s to help reach the deep pockets. The smaller blades of the mini 5s and micro mini 5s will help to reach in tight areas of vertical bone loss. For scalers, Nevi 1s and 2s would be used to reach heavy anterior and posterior deposits. For ultrasonic inserts, the magnetostrictive 1010 after 5 inserts would be used for gross debridement and heavy calculus removal. Robert could be prescribed pilocarpine for saliva stimulation and fluoride gel for caries prevention. Xerostomia typically affects the oral cavity by causing decay, so this is something that we would want to prevent. An over-the-counter aid that we could use to prevent xerostomia is biotin. We want to make sure that when Robert's brushing, he is using the Bass technique and a power brush. He could use Crest cavity toothpaste, but only a pea size to avoid abrasion. We'd like to make sure that he's using Listerine Zero alcohol because alcohol dries the oral cavity more than it already is. So we would not want alcohol in anything that Robert's using. For patients with COPD, we need them to add protein such as egg, cheese, meats, fish, beans, and nuts to their diets, and focus on consuming lean meats, fruits, vegetables, dairy products, and whole grains. They need to reduce their salt intake and avoid large meals, substituting smaller meals more frequently. If the medical team recommends, then oxygen can be supplemented if you're having difficulty breathing after eating. Potassium is also very important for lung health, so this would be important for a COPD patient.